Vishnu, few minutes and we start then.
Yes, sir. To 8:32 हो गया. We can a couple of minutes we can wait and then.
Yeah.
My request to everyone is to please stick to the time. Our usual criticism is that we overshoot our time and we go till 10:30. So Saturday evening, everybody we should not keep people in the
Yeah.
webinar for long period of time. Yeah. Luckily, it's not India-Pakistan match today, so we'll have.
Yeah.
So,
Yeah.
I think we can start now, sir. Yeah.
Yeah. So there are around 50 attendees. So
Yeah.
will we start, Kim?
Yeah. Yeah.
So good evening, everyone. Welcome to this yet another edition of Neuromuscular Subsection meeting. And today we have interesting topic of hematological malignancy and associated neuropathies. And we have an esteemed panel of speakers today. The session will be moderated by Dr. Vinaya Bhandari. Dr. Bhandari is a neuromuscular expert and she is a consultant neurologist at Jaslok Hospital in Mumbai. Dr. Megha Dhamne is a consultant neuromuscular expert at PD Hinduja Hospital in Mumbai. And Dr. Azad Irani, he is a consultant neurologist at Jaslok Hospital. So let's start. I think, Dr. Vinaya, you can start from here now.
Sure. Can you all see my screen?
Yes.
Yes, you can just go to the full screen.
Okay.
Yeah.
Okay.
Perfect.
Okay. So good evening, everyone. So the topic, it's an interesting topic of hematological malignancies and neuropathy. And I'll start this interesting case. So this patient is a 58-year-old male. Patient reported symptoms since 2 years. Patient reported symptoms were subacute in onset. He started complaining of subacute onset of burning sensation in the sole of his feet to begin with initially, which progressed up to his mid-leg and then involved the distal upper extremities over the next 6 to 8 weeks. Along with the burning sensation, he also reported a tingling sensation in the distal lower extremities at the same time, which progressed up to his mid-leg and then involved the distal upper extremity over the next 6 to 8 weeks. In the last 1 week, he started complaining of imbalance while walking, especially on uneven surfaces, and he reported one episode of fall. Fortunately, he did not sustain major injury during that fall. In the last 6 months, he started complaining of tremor involving the upper limb bilaterally. It was mainly when he assumed a particular posture. There was no history suggestive of focal weakness in the upper or lower limbs. There is no history suggestive of radicular symptoms or autonomic dysfunction. There was no history suggestive of ocular or bulbar symptoms. Patient reported a weight loss of 6 kgs in the past 6 months with loss of appetite and swelling in his lower limbs. Patient was able to ambulate independently and did not require any assistance for his day-to-day activities. With regard to his past history, he is known hypertension. He is a known case of hypertension on treatment. Social history, he consumed a mixed diet and there was no history of addictions. Like there's no history of alcohol consumption, no history of smoking, no history of drug addictions. There was no drug or toxin exposure as per the history, and he did not have any history suggestive of neuromuscular dysfunction in the family. On examination, the patient had no pallor. The clubbing was positive. He had white nails. He had bilateral pedal edema. On examination of the blood pressure, there was no orthostatic drop in blood pressure. On examination of the central nervous system, cranial nerve examination was normal. On assessment of the motor examination, he had hypotonia at the ankle joints. Power was 5/5 throughout, other than weak ankle dorsiflexion bilaterally. Left side more affected than the right side. Patient was able to walk on his toes, but had difficulty walking on his heels. Patient had areflexia and bilateral plantars were flexor. On examination of the sensory system, he had impaired joint position sense and vibration distally at the toes. He had graded sensory impairment to pinprick, temperature, and light touch up to his distally in the lower limbs up to his mid leg. Patient had an ataxic high steppage gait and Romberg's was positive. His inflammatory rash-built overall disability scale was 28 out of 48. 28, the score of 48 in IRODS is considered to be good and 0 is the worst score. So the patient scored 28 out of 48. And the overall neuropathy limitation scale, out of 12, the patient scored 3, where 0 is a good score and 12 is maximum disability. So basically, to summarize, the patient is a 58-year-old male with history of subacute onset of paresthesia in the distal lower limbs and the upper limbs, with sensory ataxia, bilateral foot drop, and tremor. So based on the history, we had the following differential diagnosis. We thought that we had 3 differential diagnoses of distal acquired demyelinating symmetric polyneuropathy, the CIDP variant, a paraproteinic neuropathy, and the third possibility was a nodoparaneuropathy. So we started assessing the patient. We got the nerve conduction studies done. So nerve conduction study showed a primary demyelinating neuropathy. As you can see, the sensory nerve conduction studies in the lower limb are unobtainable, and in the upper limb, the sensory nerve action potentials are attenuated, but with significant slowing of the conduction velocities, being in demyelinating range. Similarly, the motor nerve conduction studies showed the responses could not be obtained in the lower limb. And in the upper limb, there's significant prolongation of the distal motor latencies with attenuation of the compound motor action potential amplitudes and significant slowing of the conduction velocities. There was no conduction block or temporal dispersion seen in the study, in the electrodiagnostic study. So it looked like a uniform demyelinating neuropathy. So we investigated the patient. So on investigation, CBC showed erythrocytosis and thrombocytosis. His creatinine was 1.8. It was elevated. The metabolic workup was normal. MRI whole spine did not detect any abnormality. Serum protein electrophoresis with immunofixation showed the presence of M band. Patient had IgG lambda, which was elevated. Free light chain assays, the free light chain ratio was normal, but the kappa and lambda chains both were elevated in this case. Beta-2 microglobulins were elevated, and vascular endothelial growth factor was 818, which was elevated. Urine for Bence-Jones proteins were normal. Patient underwent a bone marrow biopsy, which did not show evidence of plasma cell dyscrasia on the bone marrow biopsy. So we went ahead and did a PET scan, and PET scan showed a metabolically active lytic lesion with sclerotic margins involving the right acetabulum, ischium, and ischial tuberosity, which is seen here. This is the CT cuts of the patient, and it shows a sclerotic lesion here in the right acetabulum, ischium, and ischial tuberosity. So we went ahead and biopsied the solitary expansile lytic lesion. And this is the CT-guided biopsy report. The patient was confirmed to have a plasmacytoma. The lesion was a plasmacytoma, and patient was diagnosed as Poem syndrome. So we referred him to an oncologist, and he was given radiation and chemotherapy and is being followed up. Patient is doing well. Patient reports improvement in his gait ataxia, motor weakness, and sensory symptoms. And on recent follow-up, his IRODS is 43 out of 48, and the ONLS score is 1 out of 12. His serum protein electrophoresis and immunofixation has improved. So this is a case of Poem syndrome, and I have few slides about paraproteinic neuropathies pertaining to Poem syndrome. So monoclonal gammopathies of paraproteinemias are a heterogeneous spectrum of clonal plasma cell disorders characterized by secretion of monoclonal protein, which is made up of heavy chain and or light chain. So the clonal proliferation could be secondary to a hematological malignancy. And in the absence of hematological malignancy, the monoclonal gammopathy is termed as monoclonal gammopathy of undetermined significance. So POEMS is a rare paraneoplastic disorder associated with plasma cell dyscrasia. The acronym refers to polyneuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. The pathogenesis is not completely understood. However, there is cytokine imbalance which is seen with elevated vascular and endothelial growth factor, which is responsible for the basically elucidated in the pathogenesis of POEMS syndrome. So for the criteria for us to classify the patient as POEMS syndrome, the patient has to satisfy the mandatory criteria of polyneuropathy, typically demyelinating, and monoclonal plasma cell proliferative disorder. Major criteria, 1 out of the 3 major criteria should be present for us to for us to call the patient POEMS syndrome. So so the major criteria include Castleman's disease, sclerotic bone lesions, and vascular endothelial growth factor. And out of the 6 minor criteria, patient has to satisfy 1 criteria for us to label it as POEMS syndrome. The minor criteria include organomegaly, extravascular volume overload, endocrinopathy, skin changes such as hyperpigmentation, hemangiomas, hypertrichosis, white nails, clubbing, acrocyanosis, etc., papilledema, and thrombocytosis or polycythemia. So the skin changes seen in POEMS syndrome include hyperpigmentation, hemangioma, and hypertrichosis, which are most common, and clubbing, which is least common. Skin changes are seen in 90% of patients with POEMS syndrome. So POEMS syndrome electrodiagnostic criteria, electrodiagnostic features mimic CIDP. POEMS syndrome clinically and electrodiagnostically mimics a CIDP. So patients will have a demyelinating neuropathy with significant axon loss. Features that aid differentiation of POEMS from CIDP include less frequent conduction blocks, uniform demyelination, and disproportionate involvement of the lower limbs. So intermediate segments of the nerve is predominantly affected, causing slowing of the nerve conduction velocities, leading to higher terminal latency indices. Monoclonal proteins are predominant, monoclonal proteins are elevated, predominantly IgA followed by IgG, and almost always lambda chain will be elevated in POEMS syndrome. Vascular endothelial growth factor is highly specific for diagnosis of POEMS syndrome. And nerve biopsy will show signs of demyelination, axon degeneration, and neovascularization. So clinical challenges, it's often misdiagnosed as CIDP, leading to delay in treatment. However, one should consider POEMS syndrome in patients with refractory CIDPs. Treatment includes collaboration with a hematologist, radiation therapy if the patient has 1 to 3 bone lesions without clonal plasma cells. Usually radiation therapy works, and systemic therapy is required if the patient has more than 3 lesions or if there is marrow involvement. Hemopoietic stem cell transplantation may be effective for eligible patients, resulting in good control, neurologic response, and survival. And treatment response may be delayed or incomplete, taking 6 to 36 months post-therapy completion for patient to show neurological recovery. Thank you.
Excellent case, Vinaya. I just wanted to ask one question, Vinaya. You said that POEMS will actually is considered if you have a refractory CIDP.
Yes.
Now, sometimes, because like this patient, he actually presented what looked like a small fiber neuropathy, painful neuropathy. For good, I think 1 to 1.5 years, he had only painful paresthesias in the feet.
Mm-hmm.
In the last few months, as you mentioned, that he had started to have difficulties in walking and a mild distal weakness and sensory ataxic, which has started coming in.
Yes.
That is when I think it was basically picked up that he has a frank demyelinating neuropathies.
Yes. Yes.
But usually it comes like a refractory CIDP, and when they are not responding to the immunotherapies.
Yes. Yes. Usually it will show, usually it is missed, and then later we find out that the patient has paraproteinic involvement. But yes, I mean, overall, the only history, based on the history, patient had a subacute onset of symptom when like his symptoms progressed in 6 to 8 weeks. Like he initially had symptoms in the lower limb, and in 6 to 8 weeks there was involvement of the upper limbs, which kind of gives a hint uh, into something which is autoimmune, or uh, like a paraproteinemic neuropathy or nodopathy. That was my thinking when I was assessing this.
Yeah. Dr. Vishnu, any experience with poems? I think you've seen many poems.
Yeah, I think the year before, last year's, I think in Mumbai Neuromuscular, I presented a CPC on poems. My CPC was
You did. Yeah, I remember
and
that. Yes.
so, I mean, one classical feature which clinically is the pain. Pain, which is very uncommon in CIDP, we don't see that much pain. Usually less than 10%. Literature says 7 to 10% you see pain. Poems, usually 75% pain is there. So pain is a little unusual feature. I mean, is one clinical pointer towards poems. That one thing. Second is nerve conduction wise, when we say something, we look for, we take that things for granted that it is a demyelinating neuropathy because it's a mandatory criteria initially to require a CIDP. But sometimes you see, in the early stages at least, sometimes you see the intermediate segment involved. Only the velocities are very much reduced. The
Yes.
digital latency may not be that much involved at that point. And that is also initial clue. But most of the time, by the time it comes to a neuromuscular expert in neurology, it's been a long time patient is been on treatment or a diagnosis of a CIDP at that point of time. And it's important to recognize poems because it will not, okay, treatment-wise, it will not respond to a conventional CIDP treatment. It needs an oncologist involvement to treat them as a chemotherapy as such. So, and if nerve biopsy has come out of favor for demyelinating, we don't do nerve biopsy nowadays that much unless you're suspecting a lymphomatosis or a leprosy or a vasculitis kind of thing. But if you see the nerve biopsy, and also there's a classical difference is you don't see that much of macrophagic infiltration in poems, in which you see it in a CIDP kind of a
Right.
picture. So that is also some of the clinical features involved. And VEGF, I mean, it's very costly here. We don't do it routinely, but most of the time patients can't afford. If there is one thing which we can pick it up easily is you doing a VEGF. Most of the time, VEGF will be dignified. If you have a refractory CIDP, if you have a VEGF in elevated, that also gives a good clue. And I was interesting to know whether a PET scan was done. Was a PET done?
Yeah. So PET showed presence of a solid. So when the patient was admitted and we did a bone marrow, so VEGF was done before, which was
Yeah.
elevated. The nerve conduction study showed primary demyelinating neuropathy. So this is very, so there's no conduction blocks, no temporal dispersion. It is
Yeah.
uniform demyelination. Terminal latency indices were elevated here, like they were increased. So we did do that because they're like we can. So I'll show you the PET scan. This is a PET scan. Basically, when we did the bone marrow aspirate, there was no plasma cell dyscrasia. And then a PET was done, which picked up a solitary lesion. So basically, this is the solitary plasmacytoma causing the Poem syndrome.
So second other thing which why I was asking first PET was sometimes PET can pick up the lymph nodes. So because lymphadenopathy are part of the Poem syndrome, unless it is very large, we don't usually do a biopsy or something like that because anyway we got the diagnosis, we got the VEGF is elevated, we got a plasmacytoma,
Yeah.
most of the criteria are satisfied.
Yes.
So sometimes Castleman may be missed so Castleman something is which will be picked up only if you do a lymph node biopsy. So if you have a significant lymphadenopathy in that, because that is one thing whether you need to do a biopsy or not, because already you got a diagnosis of poems
Yes.
and where everything is there because management wise, I think Castleman especially a multicentric Castleman side for an oncologist, I think their protocol may be slightly different in how to manage a poems with a multicentric Castleman versus a poems without a Castleman disease. So in that way, sometimes the management is there. So whether I was asking for PET primarily for whether there was a lymphadenopathy was there or not.
Nothing on PET other than a solitary plasmacytoma.
Yeah. So I mean, it's a learning point. If we always say to our residents, if it's a refractory CIDP, first thing is go back and see whether it is CIDP itself. Yeah, it's a rule applies to throughout in a refractory epilepsy, refractory migraine, whatever it is. If it is refractory, go back and see whether your primary diagnosis is correct or not. If the primary diagnosis is correct, then in CIDP, most important point to look for is poems and especially if the case, sometimes these cases in CIDP is very easy. I mean, it's a little more easier to think of poems. sometimes the patients may develop diabetes also, and it will complicate the picture. And so a lot of things are attributed to diabetic neuropathies also, and in that case, a very interesting case. Yeah.
Thank you.
One thing I wanted to make, this we rely on VEGF,
Mm.
we do it, but it is mentioned that if patients have taken steroids,
Mm.
the VEGF may come normal.
Mm. Okay. Because I don't have such experience on that.
No, I'm not. It was just mentioned in one of the articles that because these patients are refractory CIDPs, they must have taken some steroids.
Yeah.
It can be
So,
normal.
in fact, I think they have in UK or something, they have done a cost-effective study also to see if we screen all CIDP at the initial itself doing a VEGF, is it cost-effective to, because in UK or in where once you diagnose CIDP, many of them receive monthly IVIGs. So the cost is whether we can pick up poems early, whether it is you will save cost in management in general if you screen everyone with VEGF, all CIDPs with VEGF or not. So that is that, but for us, it is very costly industry around. So it is not that easy to get it done here, at least.
But if there is if you are doing a serum protein electrophoresis with immunofixation, I think that should be screening for especially if there's a demyelinating neuropathy, that will be elevated, no, and then we can decide if we want to do a vascular endothelial.
Especially if you get a proper lambda.
Yes.
Yeah.
Like a IgG, IgA, or a lambda predominant monoclonal gammopathy. That should be screening, I think. And then depending on the nerve conduction studies and the SPEP, SIP, we can decide if we want to send vascular endothelial growth factor.
Yeah. And the other thing is, which we will always like to emphasize is, as a neuromuscular expert, we should not try to treat poems on our own.
Yes.
So we should get the medical oncologist into the picture.
Definitely, yes.
Yeah.
Thank you, Dr. Vinaya. So I
One
think
comment I have basically.
yes.
Nice case, Vinaya.
Thank you, ma'am.
So, basically, when we screen for neuropathies, all patients we do send for immunofixation electrophoresis, and I think that is a most important point here, because sometimes you see the treating physician or the neurologist would send in for protein electrophoresis only, which may not be sensitive to pick up the abnormal paraprotein. So I think serum immunofixation electrophoresis by quantitative method, and at least 24 hours as well urine electrophoresis by immunofixation electrophoresis would be more crucial. Any thoughts on that, Vishnu, Rakesh sir, anything?
Absolutely. I mean, immunofixation is, it has become a standard gold standard investigation in all CID, all demyelinating neuropathies. Having said that, so everyone who has access to do it should do it. Mostly, many places you may not have access to do it. So that is another thing. If you have access and affordability is not an issue, it should be done for all patients. It will pick up, as Dr. Vinaya told, that it should pick up most of the conditions, and that should stimulate further investigation into the picture.
Also, the free light chain assay, I think that also should be done in most of the cases, along with serum protein electrophoresis and immunofixation.
Usually, free light chain assay in these investigations, the usual problem is you will get a value on the borderline. So, some on the borderline. Most of the time, it is. I mean, it is normal, and obviously it will spike some interest, and we'll get work it up. But most of the time, unless it is very highly elevated, the ratio is unequivocally high. So that is
And the other thing is a skeletal survey as a part of routine evaluation for neuropathy should be also included. But what we have seen is sometimes, it's difficult to get a skeletal survey in hospitals, whereas it's easier to get a PET CT. So, that's anything that you suggest, like instead of a skeletal survey, a cost-effective method for screening, in all neuropathies, that would be helpful for these patients as well.
I think whole body PET is very easy in our
I know,
we can easily do that.
Our nuclear medicine experts are fed up with us to getting a PET scan for
Everybody is getting a
PET scan for they want an audit of how many PET positive you are getting of all the PET scans that you are getting it done. So
I mean,
let's move to the next talk, Vishnu.
Yeah, sure.
Yes, so
I'll
next.
stop share.
Yeah, thanks, Vinay.
Thank you, Dr. Vinaya. So Dr. Megha Dhamne.
Yeah.
Welcome.
Thank you. Can you see my slides?
Yes.
So moving on, I think we are talking about refractory CIDPs here. So this patient is a 65 years old gentleman, no diabetes, but controlled HbA1c for the last 10 years. My story starts in 2021, post-COVID. He had COVID, and after that, he had an episode of refractory paroxysmal atrial tachycardia requiring flecainide, multiple antiarrhythmics, and it had to be ablated. Then, soon after that, he develops a right lower motor neuron facial palsy, and he recovers. It's labeled as a Bell's palsy, probably. Then, a year later, almost, his events slowly started. He developed slowly multifocal neurological deficits. Initially, what he had was right thumb and index finger weakness. Then he had left foot numbness and a foot drop, followed by numbness in the right, fourth, and fifth finger and weakness. So, given this multifocal involvement, he underwent an extensive evaluation. Now, these events were preceded by pain, numbness, paresthesias, and weakness. So, nerve conduction showed possible C8T1. So, the ulnar and the medial CMAPs were a little on the lower side. This was all done outside before he was referred to us. So, this is the outside hospital evaluation, which I'm describing to you. So, he underwent ANCA, ESR, CRP, everything was negative. And the only thing which was positive was antihistone antibody. Now, paraprotein workup as a part of routine evaluation was done, which showed a kappa light chain. Moving forward, he undergoes a bone marrow biopsy advised by a hematologist, which was unremarkable. So, I think prior to that, a whole body PET CT was also done, which did not pick up any malignancy. Now, given that his deficits had progressed over 1 month, he was advised IVIG. However, they were not disabling at this time, so he did not go in for IVIG. Now, March, what happened is he developed diplopia. He was seen by a neuro-ophthalmologist and was found to have a superior oblique palsy. Soon after that, he develops bulbar symptoms with difficulty swallowing and a nasal twang. And he also developed breathlessness and lying down. So, because of these symptoms, somebody thought this probably could be a myasthenia. But of course, looking at everything together, you're probably dealing with multiple nerves, multiple localizations, brainstem, cranial nerves, optic nerve, peripheral nerves. So as neurologist, I'll talk about the nerve conduction later. So basically the neurologist, the treating neurologist advised plasmapheresis in view of this rapid progression. And he underwent plasmapheresis in April and he improved partially. But the question is that, he was on flecainide long term for his paroxysmal atrial tachycardia. And the question that the treating neurologist had was whether this was a flecainide-induced neuropathy. A vague thought, but interesting read, and it does cause a sensory axonal length-dependent neuropathy, which does not fit the presentation. So we come forward to May when he had a partial improvement of deficits. The bulbar symptoms had improved. He was out of a ventilator. He was on a ventilator transiently. And he was with deficits, right ulnar neuropathy, which there was a motor weakness now with atrophy and weakness in the left foot, minimal, he's walking with a minimal of foot drop. What happens further is he develops now a left LMN facial palsy, I think 15 days to a month after the plasmapheresis. This was in May. So I put on the other side, but this is May. Then he develops severe pain in the right thigh and leg, followed by right shoulder pain, weakness, and atrophy. So, if you see his progression, he's rapidly progressing, responding partially, and developing new symptoms, multifocal involvement. That's how he presented to us. And this is where the neurologist referred to us for neuromuscular expertise. Now, this was the nerve conductions that were done outside in March and April. The first one where he had a foot drop just showed a common peroneal neuropathy on the left. However, we'll come back to it. The one in April, where his symptoms had progressed, there was a little bit of a conduction block in the right ulnar and in the left and as well as the right ulnar, and you can see the amplitude. There's probably an axon loss which is developing here. That was about it. Rest of the nerve conduction was absolutely not. So when he came to us, he had done a thorough workup. He was still progressing, and this was his examination. So residual deficits, right ulnar atrophy and wasting weakness on the right side as compared to the left. Asymmetrical, you can see here, there's an asymmetrical ulnar involvement. I'm saying ulnar because the finger extensors and the APBs are relatively abnormal. So it was probably a nerve rather than a neuropathy, like a generalized neuropathy, and asymmetrical. He also developed, while he was seeing us, he developed this abdominal bulge. So the intercostal muscles also were involved, probably. And that's where we were. As far as the sensory exam was concerned, only in the right ulnar distribution, minimal sensory loss. Distally, he had some sensory loss up to the ankle, and he had generalized hypotoareflexia. So we are dealing with an elderly gentleman. Diabetes is very well controlled. He is having a very rapid, a quite fast relapsing course over 2 months with multiple cranial nerve involvement, respiratory weakness, and as well as probably intercostal nerves. So you wonder, what is the localization here? We know it is the nerves, but what is the etiology here? So his neurologist had a working diagnosis of mononeuritis multiplex and had referred to us for a nerve biopsy of the ulnar nerve when he developed this ulnar neuropathy. But clearly this patient is worsening. So when he came to us, we repeated the nerve study. Not much changes on the nerve's conduction except for now the right ulnar, which had shown reduced CMAP, is now completely absent. You can see the clinically also it is correlating with atrophy and muscle weakness. Left ulnar did show a conduction block, minimal slowing here in the conduction velocity. Other nerves were relatively normal. So clinically, we thought, this is CIDP, subtle features of demyelination in multiple nerves, predominantly ulnar, cranial, bulbar nerves. And this was a clinical diagnosis of MATSAM. So he had come to us with all these investigations, autoimmune, vasculitis, as we had discussed earlier. So what we did was a nerve biopsy, which showed a right ulnar nerve lymphocytic infiltrates, no atypical cells, no malignancy. CSF, however, was not done. So we did the CSF, which clearly showed an albuminocytological dissociation. And MR neurography was done, which showed left sciatic nerve and lumbosacral plexus asymmetric hyperintensity. So coming back to the diagnosis, we are probably dealing with whether multiple nerves, is it a mononeuritis? However, given the cranial nerve bulbar involvement, it is favoring more of a CIDP variant, which is MATSAM. We did find subtle features of demyelination here and albuminocytological dissociation. So in June, when he came to us, he was advised IVIG. He got IVIG, he received IVIG, and he improved. 2 weeks later, not surprising, the way he has behaved, he continued to progress. Right shoulder abduction weakness had improved. Muscle loss had improved. He again developed new weakness and little bit of a pain as well each time preceding the weakness. He received hence IVIG maintenance dose as after the first dose. He wasn't willing to get steroids. He was diabetic, but he was very cautious about his health. So he refused steroids. So he was willing for IVIG and followed by rituximab. The diagnosis was MATSAM. So he did very well. This was September 2022. He got rituximab. The last dose was in March. He was on March of 2024. He was on maintenance rituximab 1 gram 6 months. So he was in remission for 2 years. And that's where his story begins again. He comes back. For 2 years he remained in remission. He was very happy. He could walk normally. No other worsening. Now March is 2024. So last year is when he received his first his maintenance dose of rituximab. He comes back in April, and he says again, now every time he has his weakness, it's preceding by pain. So he was little worried because of the progressive course that he had. He said, again, I have left thigh pain and I'm worried. So I think here, if I remember correctly, he had this thigh pain going on since March. And, April, he said it's kind of quite severe. And now I have buckling of my knees, not able to walk properly. So when he came to my clinic, he required a little bit of a support to stand up, like a proximal muscle weakness. And I don't have his videos, I'm sorry, but little bit of a wide base gait when he was walking. So my first thought was, is it a CIDP relapse? Did the nerve conduction study? However, it was unremarkable. This was end of April. He was on high dose statins for his hyperlipidemia. So I did a CPK level, which was also normal. EMG was normal. So I suggested we go in for IVIG. This was first week of May. He had a partial response. However, he continued to require support to stand and walk. And he became more and more ataxic with a wide base gait. So this time, because of predominant sensory ataxia that he had, I suggested we go for the neuropathy panel. I'll discuss about this. I'll come to it later. It was positive for, I think, one of the neuropathies, I think one of NF140. So, he continued to progress, no clinical improvement. Family is getting frustrated, patient is getting frustrated now. So because of this neuropathy panel, which was positive, we suggested that we start steroids. So in June, he was started on steroids and he received another course of IVIG. This time, because the wide gait was worsening, he required more support to stand. I did an MRI spine and brain screening. And this is what the spine showed. So this is showing long segment hyperintensity, stir intensity in the thoracic cord. Sorry, I don't have the cervical spine images, but you can see there is a patchy hyperintensity, which is in the posterior aspect of the thoracic cord. It's a long segment transverse myelitis. So that's probably the reason why he had this ataxic gait and difficulty standing and walking. So, he also had an episode where he transiently had this difficulty walking after improving a little bit. Partially he used to improve with IVIG and again go back to the same state. So we also screened his brain, and the question is, are we dealing with central demyelination in a patient who had been treated with the peripheral demyelination like the CIDP? So this time, because of the transverse myelitis, we send off his entire panel for autoimmune workup. NMO, MOG, repeat CSF showed reduced proteins, cells were normal, and this time, as I mentioned, prednisolone was started, whether this was a nodopathy, whether it is a Sjogren's syndrome. So we are dealing with a refractory transverse myelitis here. I repeated CT scan here, PET CT. It did not show any other uptake except for the spinal cord uptake. So he comes back. Obviously, he has not responded to 2 courses of IVIG. Still continues to have difficulty standing and walking. Now he has low-grade fever. Nerve conductions repeated in May and July showed improvement of the demyelinating features which were there earlier, with no conduction block, no features of demyelination. In fact, reversal of the ulnar conduction block which was present earlier. Little bit of a sensory neuropathy was there. MR neurography showed resolution of the sciatic hyperintensity, which was seen earlier. And the PET scan showed T3 to T11 uptake with little bit of a brainstem and left cerebellar uptake. So this time we decided to go for plasmapheresis because of 2 doses of IVIG, which he was non-responsive to. However, 15 days after the plasmapheresis, almost 15th of July, wife calls me that he has slurring of speech at times now. There is a clinical worsening. He continues to have low-grade fever. And for the first time now, he has a foot drop apart from the proximal weakness that he had. Left foot drop followed by right foot drop, and clinically just worsening. Slowly he develops quadriparesis, not able to sit up, continues to have low-grade fever. Multiple CSFs done during this time, which have been unremarkable. Infectious disease panel has been done, which is unremarkable. He becomes more and more obtunded, so that we had to intubate him for very poor GCS and quadriplegic. So this is a patient here where we do not have any diagnosis here. We've done multiple IVIGs, I think once or twice plasmapheresis. So here we are wondering, what should we do now? We do not have a diagnosis here. We are just hitting hard. We're dealing with a central versus peripheral demyelination on the background. Should we go ahead with the next dose of rituximab here or cyclophosphamide? But he's having persistent low-grade to high-grade fever, and we could not take that decision whether to go in for rituximab or cyclophosphamide. And clinically, definitely, he was worsening. So what we did is we repeated the MRI. MRI brain from the previous MRI, which I'll show you. Sorry, I have to go back a lot. But the previous MRI did not show these flare hyperintensities. This MRI clearly shows a lot more hyperintensities between June to August. So July to August, 1 to 2 months, there's a rapid increase in the number of lesions in the brain MRI. However, they were non-contrast enhancing and no diffusion restriction was seen in this patient. So are we dealing here with a case of refractory transverse myelitis? Definitely his CIDP is no longer present. He was in remission as far as the CIDP was concerned. Rapid deterioration, rapid worsening, PET not showing any other malignancy. We are wondering, with the new brain lesions and clinically obtunded state, is this a CNS lymphoma affecting the brain and the spinal cord? And we had planned for IVIG and cyclophosphamide, but we wanted to know if we can get a biopsy from anywhere. So we had multiple radiological opinions from our radiologist and outside. And finally, one of those lesions here, one of these lesions, I think the right frontal, we got the brain biopsy done, which does show a lymphoma. So this slide shows CD positive B cells here and in the parenchyma and the perivascular area, which show a very high proliferative Ki index in the B cells. And this was not seen in the T cells, which were little scattered. So the questions we had open to the discussion as well is, initially his CIDP was very atypical. Multiple asymmetric cranial nerve involvement with cranial nerve involvement, very painful to begin with as well. And as we discussed, pain is not a feature of CIDP. So he used to have a severe pain preceding the weakness, and that made us do a nerve biopsy, despite the fact that there was conduction block and subtle demyelinating features, to see if this was really an infiltrative lesion to begin with. In fact, we suspected vasculitis initially, despite the demyelination, but there was no vasculitis over there. So did we miss neurolymphomatosis? how did you develop lymphoma despite being on rituximab? The neurofacin antibody is always something that we should correlate clinically, and patients refractory to treatment consider biopsy for definitive diagnosis. What happened next is he was diagnosed in August of last year. He received 7 cycles of chemotherapy, which included treatment with rituximab, methotrexate, vincristine, procarbazine, and cytarabine was given for 2 cycles. And wife sends me a picture after the 6th cycle. He's sitting up in the bed. She was so happy. This was a patient who was grade 3 GCS, intubated, quadriplegic, and we didn't know for a month. He was like this for a month. For 4 months, we had no diagnosis on him. We were just giving IVIG and plasmapheresis, and I think that's what was, it takes about 3 weeks, 3 months sometimes for a patient to respond to IVIG if it is a refractory CIDP. So that's where we are. And finally, now he completed his chemo in January of 2025, almost a year. He's had this course. He's now talking. He remembered me when I met him last time. He had come for a follow-up MRI in February first week, where you do not see any spinal cord lesions here. He's developed new brain lesions. I don't know if you can appreciate. He had a lot of new brain lesions. This was November of 2024, but November till now, there are no new brain lesions. So he's in a partial remission is what I would say at this point of time. Thank you. I am not going to discuss anything. The case was quite good for discussion.
Fantastic. Excellent case, Dr. Megha. And I must congratulate you for ultimately clinching the diagnosis and doing extensive workup, and finally, you could make a very, very difficult diagnosis. I think it would have been the same had anybody else seen the case. It's so difficult to really find the exact diagnosis. But I believe one biopsy was done of the ulnar nerve.
Yeah. So, a question I still don't have answers, because let me tell you. So the biopsy, initially he had a very difficult CIDP. So if it was me, I would have not done an ulnar biopsy in the first place. But his neurologist insisted, who sent him to me, he insisted that I do the ulnar nerve biopsy because it was a painful and he suspected mononeuritis multiplex. I'm glad we did it, because when we went back after this episode, we discussed with the pathologist, and he said, the lymphocytic infiltrate we see in CIDP, what he said was B cell predominant. And he said some T cells were present over. I think I have to go back and see. But he said there was something retrospectively, it is easier. But, he said retrospectively, it was a little atypical lymphocytic infiltrate, which was there in his nerves. However, see, we discussed with the oncologist as well. Neurolymphomatosis remaining indolent for 2 years is very unlikely. So he did have an episode of CIDP and now presented with the CNS lymphoma. That's what is the consensus that we all have discussed. It's a tough case. Is his wife kept insisting? I think the credit goes to his wife because she kept insisting, I want to make him better. What is it? What is it? And even by 2 years, we were like close family. We couldn't get a diagnosis. This guy is on a ventilator, quadriplegic. He's just worsening, persistent fever. We couldn't give him cyclophosphamide or rituximab because we didn't have a definitive diagnosis. Nerve conductions are looking normal here. So where are you going to get the biopsy from is what we wondered when we had the spinal cord lesion. And the brain MRI was not classical for lymphoma, non-enhancing, no diffusion restriction. I'm lucky we have a good neuroradiologist who said, no, go ahead and take the biopsy from this particular flare lesion, which is good. And I think hats off to Dr. Megha Upin, who did the brain biopsy for us. And she said she clinched the diagnosis. She picked up those Ki positive cells and the CD20 cells in the brain parenchyma, whereas the biopsy at some other center said it's a normal brain parenchyma. So I think sending the biopsy to the right place, right center, and targeting the right, I think the wife also agreed easily for a brain biopsy, because sometimes it's a resistance we get from the patient's relatives. But I think she wanted the diagnosis. So I think that's what helped. And he's improved remarkably. He's not walking, but he's walking with some support now, and he's talking. Initially he was not recognizing anybody. His cognition had gone down before he went on a ventilator, and he's turned around 180 degrees. We are all happy for him, basically. So that's nice. So I thought I'll discuss this, even though it's not a neuropathy, but it was a tough case. And I'm going to lymphoma discussion to Azad.
No, it's a usual typical CPC case, right? So
Yeah.
whenever a case presents like this, we'll say, oh, it's going to be lymphoma. It's coming.
I know.
It's going to come. It's going to come, lymphoma. So something of that sort. I mean, but the only, I think the one thing which we saved him was the fever. I know if there was no fever, he would have given cyclophosphamide by this time at that point of time. So the fever was the one which probably precluded not to give him cyclophosphamide at that point of time. I was worried. Want to know when initially one of his MRIs showed some involvement of the plexus. I think one of the plexus also. Did the PET picked up anything on that? No.
He had also undergone bone marrow biopsy at that time. This was all done by his neurologist, who had thoroughly worked him up and then sent to us. When the initial time when he was.
You're saying something about T-cell lymphoma also. So usually, it's very unusual for a lymphoma, CNS lymphoma, not to have an enhancement, no enhancement of this one. But T-cell lymphomas are known to sometimes present without an enhancement kind of thing. And T-cells usually have a very bad.
It was a B-cell lymphoma.
So T-cell, okay. The T-cell are usually bad also compared to B-cell lymphoma. That's one thing. And second thing is he would have been indolent because he received rituximab at one point of time. Probably that also would have kept him under control for some moment of time. Anyway, interesting case.
Yeah.
Dr. Megha, there is a question if you can take. Why did you say that he developed a lymphoma in spite of being on rituximab? Is it protective?
So as a part of treatment for lymphoma, you would give rituximab. In fact, rituximab was first started. It was the first, in lymphomas and malignancies, basically in these malignancies, it was first used. And then now we are using it for neuropathies like autoimmune and demyelinating neuropathies. So that's why I thought it was atypical, that he was on rituximab. So how did he develop a lymphoma?
Yeah.
The learning point is that we should get to diagnose. That's it.
And these, I think, neuropathy antibodies should be taken in the clinical context.
Literally, that kicked us off when I had this sensory ataxia kind of a finding, and I was excited probably because we were talking everywhere about neuropathies and.
And we are getting all kind of reports also. Everyone is neuropathy now. All are now neuropathy positive one way or the other.
So, you don't know what you do with these antibodies which are positive. So his Sjogren's antibody was positive and neuropathy antibody, neurofacin antibody was positive. So that's where, I got distracted as to whether we are dealing with the central demyelination. And then, these cases are reported, central and peripheral demyelination. In Sjogren's, we see that. In neurofacin 155, we see that. So they are reported. It's not that it's rare. You Google and you'll find every case reported. But I think
we have Dr. Khan here. Dr. Khan, welcome, sir. Can we have your comment on this interesting case? Good evening, sir. Sir, you are I think muted.
You can hear me now?
Yeah, yes, sir. Yes, please, sir, please.
Is there a possibility of reactions to rituximab?
That's a good thought, which we also did think whether it was some kind of a malignancy because of rituximab. I don't have answers to that. I've discussed with oncologists and they said that probably not. They have not seen this. Anybody else? Any thoughts? I will really appreciate.
But he responded to Archop, I mean, this
Yeah,
rituximab-based
that's
chemotherapy later also, right?
Yes. Yeah.
Yeah.
This is Dr. Sunil. I am an oncologist at Jeslo Hospital. If I can pitch in.
Yes, sure.
Please.
So, this is a very interesting case, and we also come across many of primary CNS lymphoma getting diagnosed because they take a lot of time in evaluation. Pertaining to the question of no response to rituximab, single agent rituximab has a very limited activity in primary CNS lymphoma.
Yeah.
So, high dose methotrexate is the main drug used for treating this primary CNS lymphoma. So that could be the possibility that patient was progressing on single agent rituximab. After he was started on methotrexate and all that de-Angelo's protocol, as we have seen, patient has responded. One more thing to add, this response, ideally we should consolidate with autologous bone marrow transplant because the responses may be short lasting, and hence guidelines recommend that once a patient achieves CR, we should consider the option of autologous HSCT.
Wonderful. Yeah, thanks. So we've just sent him to Tata for a second opinion, but this is also highly appreciated, and I will discuss this with the family as well. Thank you so much.
So thank you so much, Dr. Megha. I think we are running short of time. I think we can move on. So welcome, Dr. Azad.
Good evening, everyone. Yeah. Okay. Very good evening to dear teachers, colleagues, and friends. Thank you to the neuromuscular subsection of IN for having us all here. So after two very, very nice cases where everyone was so proud about how we got to the diagnosis and the outcomes, I'm not sure if you all are going to be so happy with this case. So let's begin. 23-year-old young male. He became symptomatic in August of 2023 when he had generalized weakness, extensive fatigue, breathlessness, and rapid abdominal distension. Workup revealed hematological abnormalities in the form of anemia with very high WBC counts and thrombocytopenia. Subsequent workups, including bone marrow and PET scan, etc., diagnosed him with a Burkitt's lymphoma. CNS was not involved. Burkitt's lymphoma with CSF testing, CNS not involved at the onset. So this was his diagnosis. The genetic marker is also there. During this admission, he also went into tumor lysis syndrome and his creatinines had shot up past 8. Subsequently, he was stabilized. He continued to be on the regimens, the full form of which I have mentioned below, and even the repeat CSFs. So because he was a high-grade Burkitt's lymphoma, he had already received 2 cycles of empiric intrathecal chemotherapy, triple chemotherapy with steroid, methotrexate, and cytarabine. So they said we have to give it empirically for high-grade Burkitt's. Now the neurology story starts. So on the 30th of November, approximately 3 months into his illness, he presented with 24-hour symptom onset, where he started with left facial weakness. So his eyelid was drooping and his face was drooping, and progressing to bilateral symmetric weakness of both upper limbs. So with this history, he was admitted on the next day, that is the 30th of November. On examination, he has always been morbidly obese, weighing, I think, 120 kgs plus. Basically, his BMI was 45. So morbidly obese, otherwise he was conscious, alert. He had a high pulse rate. Not too sure whether it was an autonomic manifestation or septic, because he was already harboring infections at that time. And on CNS examination, we had a left lower motor neuron facial palsy with bilateral areflexic upper limbs, 3/5, bilateral areflexic lower limbs, however, they were 5/5. So at this stage, we can't really say if the lower limb areflexia is pre-existing due to the chemo or not. So now with this history, what next? What are we thinking? What are we going to do? Let's take a 10-second pause. So let's think, what could this be? Is it an infiltrative neuropathy, what we call neurolymphomatosis? Is this a descending GBS? Could this be a meningitis because of so much chemo and all that is gotten? Or could this be any of the above? Obviously, we keep our options open, any of the above. So what should be done next? Obviously, all of the above. So we do all of the above over the next 24 hours. So a CSF done does show albuminocytological dissociation. So we have 4 cells and 81 proteins. EMG, so this is basically within 72 hours of symptom onset. EMG nerve conduction, we have an early radicular neuropathy. So we basically have H reflexes. So there is some suspicion going into GBS, but really nothing much to say. But again, it's day 3. So the plan was obviously we'll repeat it in a few days. And an MRI was also done because this is a high-grade Burkitt's and we have some asymmetric findings on examination. So just show everybody, these are the facial nerves that we are looking at. Facial nerve, okay? Here, this is the normal MRI of a normal person. The facial nucleus starts and then it loops around and this is how it goes out. Now, it was reported as a mild enhancement of the left facial nerve. Now, this is very minor, can barely appreciate it, but that's where the radiologist has pointed it out. So, an asymmetric facial nerve even on MRI, but very, very mild to really say anything. So now with albuminocytology, with firstly his symptoms, left facial element, bilateral symmetric upper limb areflexic weakness, albuminocytological dissociation, and these EMG and MRI findings. What should we have done next? So we thought in terms of GBS more and obviously went ahead with IVIG. He was quite unstable for plasma exchange because of his sepsis already being there and his pulse rate really sometimes even going up to 140. So we started with IVIG. Because of his body weight, he required 40 mg per day for 5 days. So we are almost into day 4, reaching day 5 of his therapy. However, there has been no change in his CNS status. The lower limbs have probably become a little weak, but we can't really say if it's due to all the sepsis and steroids and all those multiple things. So he remains hemodynamically unstable. He is tachypneic, tachycardic in sepsis on antibiotics and CNS remains the same. Now, what next? Are we thinking that this is probably a resistant AIDP? And should we go ahead with IVIG? Should we repeat a CSF to see if this is a Burkitt's which has just blown out? Should we repeat? Should we think of plasma exchange, too risky? Or should we think of going in for rituximab? So we took a couple of more days. Obviously, we allowed the IVIG to get completed. We saw how he's doing. His sepsis also we wanted to improve before we take any further calls. So by around day 7 of his admission, we had finished the IVIG and sepsis was better. So we decided, but he CNS wise had not improved. So the oncologist felt strongly that they have seen Burkitt's lymphoma previously presenting with such conditions and generally they don't respond very, very well. So they thought, let's hit hard with rituximab, which may help a resistant AIDP. We're not sure how fast it helps it, but still it may help it. And plus, it may help the Burkitt's. Anyways, the other thing against plasma exchange, I have said he was unstable. And against IVIG is that his creats had again started shooting up. He was already at 2.4, 2.7 or something. So even a repeat IVIG was not the greatest idea. So in all, keeping everything in mind, rituximab targeting both GBS and the Burkitt's was the thought, and that's what was done. So he received 500 mg per, that square feet dose wise, he received 700 mg. And the next day, he even received another, that is his third cycle of intrathecal triple chemotherapy. Over the next 3 days, he was a little better. He regained his truncal power and he was even being mobilized onto the wheelchair. His sepsis was better, so we're not sure what we could attribute it to. And he was still hemodynamically still very unstable. We repeated 2D echoes, everything to see if he's having any sarcosubo cardiomyopathy or any stress cardiomyopathy, anything, nothing much. Now what started happening is the blastoid cells started reappearing in his peripheral blood smear. So the Burkitt's was coming back. Again, we were not sure what is to be done. We were really not having great options in front of us. Since the blastoid cells were back, high-dose methotrexate was suggested by the oncologist. 3-gram dose was given. Another intrathecal was done. We were hitting hard on the malignancy. Any thoughts what we could have done next? Well, by around the 17th or 18th, he had gone on to the ventilator, not doing very well on high supports. And a few days later, he succumbed to sepsis and ventricular tachycardia. So we've had two very, very good cases. The reason for adding this case, which was different to the other two cases, is because this was a diagnostic dilemma. Not every time will we have answers. And that's why it's important to even show cases where we don't know what's happening. So what was this finally? Can we still answer it? Was it GBS? Well, to support it, we could say the rapidity of symptom onset possibly suggested GBS. The areflexic, rapid, symmetric upper limb weakness would also favor GBS. The albuminocytological dissociation, number 3, and the nerve conduction, which had some involvement, questionable, maybe number 4. So 3 or 4 points supporting GBS. Against it was, I mean, in general, atypical descending GBS is atypical, especially now that you have an unilateral facial nerve. And obviously, there were enough red flags in this case. If we see the Brighton's criteria, also it says the last line is actually the most important. Rule out other causes. So with Burkitt's and sepsis and 20 other things going on, we were really not sure what we are looking at. So finally, yes, this case remains a dilemma. And we never know what he had, but definitely between these two. We tried to hit hard for both, but probably the sepsis and the other events did not allow him to recover. So with this case of diagnostic dilemmas, let's have a very short talk on lymphomas and neuropathies. So lymphomas are basically malignant hematological neoplasm of lymphocytic origin. They represent 3.4 cases of cancers worldwide. The incidence is higher in developed nations. Basic risk factors could be many, so everything is there. Lymphomas, like we know, were one of the first cancers to be responsive to chemoradiation, mainly the Hodgkin's. Now, if we see the classification of lymphomas, let's come down to the box below. The case that we have, Burkitt's, is in the highly aggressive phase. So we were dealing with something really difficult right from the start. And he was the grade 3 of the highly aggressive. So we were dealing with highly aggressive of the highly aggressive. In general, lymphoma and neuropathy, let's go to the first slide. Mechanisms. Commonest cause of neuropathies, which we will see in any patient with lymphomas, is drug-induced. So chemotherapy-induced, symmetric, lower limb length-dependent, axonal neuropathy. The whole sentence which we say is the most common. In fact, it forms 60 to 70% in most case reports. The other iatrogenic neuropathy we see is radiation-induced. It obviously presents much later. Next is a paraneoplastic and immune-mediated neuropathy, like in our case and Dr. Megha's case previously. So AIDP, CIDP, vasculitis, etc. And lastly, but most specific to lymphomas, is the neoplastic, the infiltrative neuropathies, where the cells are infiltrating the nerves, whether it be a hematological spread or direct nerve infiltration or as a contiguous spread after the dura, etc. So basically, they can present with cranial nerve palsies, commonest being the oculomotor nerves, followed by the facial nerve, followed by the fifth nerve, like the numb chin syndrome, etc. Followed by rarely, optic nerve is only rarely reported. Next, plexopathies, again, asymmetric. The importance here is asymmetry makes us consider neoplastic infiltration. And all this is called neurolymphomatosis when the cells are infiltrating. When do they occur? So neuropathies in lymphoma could even be the presenting feature of a lymphoma. And in others, it could come during the diagnosis and treatment of the lymphoma. What are the mechanisms of neurolymphomatosis? So like I said, they will directly infiltrate a cranial or a peripheral nerve or a plexus. They can even go via hematogenous spread, or it could be due to amyloid deposition or intravascular lymphoma causing intravascular proliferation. Whenever cranial nerves are involved, we must remember very likely there is meningeal involvement as well. Regarding the commonest neuropathy, which I mentioned, I won't talk much into the details of the different neuropathies which the different chemotherapy agents cause, but like we know, they are the commonest and there are very specific. So taxanes will cause small and large fiber neuropathy. Platinum-based will cause mainly large fiber. The Vinca alkaloids can cause everything: sensory, motor, small, large, autonomic, cranial, everything. Bortezomib is the painful small fiber neuropathy. Oxaliplatin has this very classic acute transient neuropathy. Suramine we always used to answer in our MCQs, GBS. Cisplatin can have ototoxicity. Thalidomide we know is a sensory neuropathy. But the question here is any cancer therapy induced neuropathy reversible? And if yes, which one? Next, yeah, is radiation-induced neuropathy reversible? So just two answers here. Yes, cancer chemotherapy in the era of immune checkpoint inhibitors should always be considered. So our classic chemotherapy agents which we used to use, no, they are, I mean, if at all they'll self-resolve, otherwise nothing much can be done up for them apart from the different papers which we read on some amount of vitamin E, L-carnitine, alpha lipoic acid, nothing much really that we know of which can reverse. But if the patient is on immune checkpoint inhibitors, we know immune checkpoint inhibitors are very, very good for the treatment of cancers. However, they unleash the immune system and hence we have a whole host of autoimmune neurological conditions, starting right from autoimmune encephalitis to autoimmune myositis to autoimmune neuropathies. The good thing is many of them recover on stopping the agent, number one. Number two, the other majority will stop with just a low dose of corticosteroids, 1 mg per kg enough. Rare people will need pulse steroids or IVIG or plasma exchange or long-term immunosuppressants, but that's very, very, very rare. Otherwise, most people will reverse very nicely. So something to be kept in mind. And what about radiation? There is a condition which I came to know when I was reading for this talk called radiation recall syndrome. So normally radiation-induced neuropathy occurs after a long time. It is due to direct radiation damage to the axons and it is an axonal neuropathy. However, radiation recall syndrome is a rare neuropathy where the nerves which were in the radiation bed, after a few weeks, not very long, will suffer an inflammatory response. Why we don't know, an inflammatory response of the nerves, and they are demyelinating neuropathies. So they are even amenable to treatment. That is called radiation recall syndrome. Right. Investigative steps, we have 4 main investigations. Electrophysiology remains the mainstay. It helps us to know the type of neuropathy and hence shortlist on the possible etiology. And obviously same, the symmetry, asymmetry, the overall electrophysiological reports helps us shortlist on the etiology. Imaging, MRI helps, PET CT helps. Nerve ultrasound in capable hands also helps if the nerves in locations which are superficial. CSF, the CLPD is a chronic lymphoproliferative disorder panel. So they check for all the lymphoproliferative markers also. So CSF for the whether the CSF is involved. So we can do a basic cytospin where we send multiple samples. We can do a flow cytometry, which does not need as much sample as cytospin. We can do it in lesser amount, or this CLPD panel. And biopsy, obviously, when necessary, it can be confirmatory. So these are the investigative steps. Electrophysiology, like I said, the commonest is toxic, but that's an axonal one, so not great news for the patient or the doctor. The asymmetric one tells us there is probably something more vicious going on inside, and we need to treat the cancer harder. And the demyelinating ones, obviously, good hope because they are reversible. Not to say that the neurolymphomatosis cannot be demyelinating or symmetric. It can be at times. Scan. Important. What is the important point to know in PET scan is be aware of non-specific enhancement. So these are people who are already immunosuppressed. They may also be harboring infections. So on the PET scan, what we may see will be some amount of malignancy, also some amount of infection also. So we may get confused as to the extent of distribution. That's where the SUV value helps. SUV value is the standardized uptake value. The higher it is, the more the chances of it being malignant. Above 8 or 9, they say is very strongly malignant. Below 5 is very strongly benign or infection. And in between is in between. All these imaging modalities help tracking the treatment response also. USG, like I said, if done in capable hands, can be very good. This is an image I found in one of the articles where if we see, the sonography is actually showing it as well as the MRI. So sometimes well done, when done correctly, the USG can obviously be much more less expensive and less invasive, and can be equally useful even in tracking response. This is a new thing again that we came across. That is a whole body diffusion MRI. That helps very often, they say, to know the amount of spread, amount of involvement of the lymphoma, and in staging it and subsequent treatment response as well. Last but not the least, treatment approach. Obviously, it depends on the treatment. So toxic neuropathies, consider changing the treatment regimen. If it is a neurolymphomatosis, go harder on the chemotherapy. We have to think of focal radiation to the nerves or the plexus very often as well. If it's immune mediated, yes, we can use steroid immunomodulator. And if we have cases like we've had today all throughout, I think the most important treatment approach is to discuss with our friends and colleagues, read, and obviously not forget to pray. So in summary, neuropathies can appear as an initial presentation or during the course of the lymphoma. Understanding the etiology is the first step. Asymmetric neuropathies raises the suspicion for vasculitis or neoplastic infiltration. Cranial nerve involvement, meningeal involvement. The most important mechanisms are toxic, but remember the other ones which are more amenable to therapy should not be forgotten. Never forget the new checkpoint inhibitors, and very often teamwork will be the only answer in difficult questions. So firstly, I cannot finish my talk without thanking everyone, especially all the residents, Dr. Nikita, Manisha, and Dr. Ira, who helped me get all the data of this case, which was 1.5 years old. And a special thanks to Vinaya, who not only helps me out with all my cases of neuromuscular, but even helped me a lot with this presentation. The only thing she did not agree with was this last slide, because this does not have a picture. Thank you.
Thank you, Dr. Azad. It was an excellent presentation, and you, I think, made us learn so many things about lymphoma and neuropathies. In fact, all the cases which we had today, I think we need to pray a lot, to really, get some chance to clinch the diagnosis. But it was an excellent case and a fantastic review.
Thank you, sir.
Sir, any comment from your side, Dr. Khan, sir?
I think that the three cases have been really amazing and of great interest. And thank you, Dr. Azad, for educating me anyway about what can be done and the different pathways. So that was a very useful talk. But thank you to all the speakers for a very, very good, instructive evening. Thank you.
Yes, sir. Thank you so much. Yes, Vishnu, any?
Yeah, I mean, today's session was a good session we saw the whole spectrum from the different cases of hematological malignancies with neuropathy as a whole.
I just wanted to ask, have you all seen something like this? I mean, the patient presented very acutely, like, started with acute facial weakness, then like within 24 hours involvement of the upper limb. And then we honestly, like me and Azad worked together at Jaslo. So we started thinking with regards to like, whether the present is presenting as a GBS in context of a lymphoma. Because when the nerve conduction studies were done, H reflexes were absent, and then there was reduced recruitment pattern. Like, normal motor units were recruiting with a reduced recruitment pattern, so which is indicative, like, of a possibly early GBS, and that is what our thinking was. But then the case like took a left turn. Honestly, like,
But
any
did
comments on
you
the?
have any?
I think possibly it was a paraneoplastic GPS. I mean, both upper limbs symmetrically and a reflexic weakness.
Yes,
Only thing, yes, you mentioned the face was only on one side.
asymmetric. Yes,
Yeah.
yes. So
Any
it was.
ganglioside antibodies was done, Vinaya? I mean, it can be helpful in these focal forms of GBS.
Sorry.
So we did not do the ganglioside anti-ganglioside antibodies. We did like like the CSF was done, which showed like cytospace negative, albuminocytologic dissociation, and the patient was sick, so we just went ahead with treatment. So we
Because as far as findings of, nerve conductions and GBS, it's very tricky because this patient had received chemo, I believe, for lymphoma. Plus, there was an underlying sepsis. So, really, what to make of absent H reflex as the early finding for GBS is tricky. But I think, I guess, clinically is what we would go. And I agree with you that this is probably what it looks like, a paraneoplastic GBS.
Any experience with immune checkpoint inhibitors induced neuropathy? Vishnu, you have seen any IC-induced neuropathies?
No,
I
not
mean,
yet.
we
At least I
we
have
talk
not seen.
about 3M.
Mm.
Yeah, I have also not seen. We always talk of these 3 M's, this myositis, myocarditis, and
We've seen triple M, myocarditis,
myasthenia.
myasthenia.
Yeah, I have seen one with myasthenia, but it is known to cause even, I think, neuropathies, which may look like GBS.
Yes, yes. I've seen a couple of cases in Canada during my training because we worked closely with Princess Margaret Hospital in Toronto. So I've seen a couple of cases with checkpoint inhibitors, and we had one myasthenia gravis here in Jaslow Hospital, which was induced post immune checkpoint inhibitors. Patient succumbed in 6 months actually.
And they can be even, I think, receptor antibodies positive.
Yes, yes.
Checkpoint induced ones.
In many of these cases, sometimes you'll have to take a clinical call because there are a lot of confounders involved. Sepsis, chemo, a lot of other things are involved. So ultimately, you take a call at that point and treat, but sometimes it's difficult to prove what is the final diagnosis at that point of time.
Yeah, the case, I mean, we had one case where, this patient had a nasal, I don't remember the details, but a T cell lymphoma, which is very rare and in remission. And that had progressed to multiple nerves and brachial plexus. So that was a rare presentation. I think if the oncologist is here, he can give us some thoughts on that. So the discussion we had during that time was a T cell does not typically involve peripheral nerves causing the neurolymphomatosis. Very classical, painful, asymmetrical findings that we had. And that was a very rare case. Typically, I think it's a B cell lymphoma which is involved with neurolymphomatosis. So, can you comment on that? I mean, anybody has seen any cases, sir?
Dr. Sunil here, ma'am.
Yeah.
So this NKT cell lymphoma is the most common. The T cell lymphoma, the most common site is nasal sinuses. And then they are very aggressive form of lymphomas involving nodes and bone marrow at the earliest. Also, tendency to involve the CNS is there. Neuropathies are not very common presentation with NKT cells.
Yeah.
Yeah, so we use aggressive chemotherapy protocols like GMOL and SMILE protocol. The response rates are also good, but still being NKT, the chance of relapse remain on higher side.
Yeah, that patient succumbed finally because it was a very aggressive lymphoma.
So,
Nice.
should we close, Dr. Vishnu? But it's already
Yeah,
10
yes, sir.
o'clock.
Taking
I
care
think
of the time.
yeah. So let's I think the next meeting is 2 months later. So it'll be the last week. So this was a special situation. Usually we do it on the Wednesday of the last month. So next should be meeting should be, I think the Goa Medical College is doing the next session, I think. Rakesh sir, this
Yeah. So
so
on behalf of Indian Academy and Subsection, we thank all three speakers for excellent meeting, and a lot of unusual cases and malignancies and neuropathies. A good review done by Dr. Azad, really updated us on that. So we thank all the three speakers. Thank you so much for joining tonight, and we look forward to the next meeting, which will be held on the last Wednesday of April.
Yeah.
It will be done by the Goa Medical College group. Thank you so much.
Thank you.
Good night.
Thank
Good
you.
night to all.
Good night.
Thank you, everyone.